Chronic inflammatory skin conditions persist over extended periods, showcasing their most distinct characteristics for months to even years, although they might begin with an acute phase. In certain chronic inflammatory skin conditions, the skin surface becomes rough due to excessive or abnormal formation and shedding of scales, desquamation. Psoriasis. Psoriasis is a prevalent chronic inflammatory skin disorder, affecting around 1% to 2% of individuals in the United States. Studies on the spread of diseases have revealed that individuals with psoriasis face an elevated risk of cardiovascular disease-related mortality, potentially due to the chronic inflammatory state caused by psoriasis. Pathogenesis. Psoriasis is an inflammatory condition mediated by T cells, assumed to have an autoimmune origin, although the specific triggering antigens are yet to be defined. Genetic factors, HLA types and susceptibility loci, and environmental elements contribute to the risk. It's unclear whether the initiating antigens are self-antigens, environmental antigens, or a combination of both. Specialized T cell populations migrate to the skin, primarily CD4 plus Th1 and Th17 cells, and accumulate in the outer skin layer. These cells release cytokines and growth factors that lead to excessive growth of keratinocytes, resulting in the distinctive skin lesions. Susceptible individuals can develop psoriatic lesions through localized trauma, Koebler phenomenon, which may trigger a local inflammatory response aiding lesion development. Genome-wide association studies have connected a higher risk of psoriasis to genetic variations in HLA loci and genes coding for proteins associated with adaptive immunity, TNF signaling, and skin barrier function. Several genetic regions are also linked to the development of psoriatic arthritis, a more serious complication occurring in up to 10% of patients. Morphology. In individuals with light skin tones, the typical psoriasis lesion is a well-defined pink to salmon-colored raised patch covered by loosely attached silver-white scales. In darker-skinned patients, plaques range from salmon-colored to hyperpigmented and exhibit grayish scales. There's noticeable thickening of the outer skin layer, acanthosis, with regular elongation of the downward projections of the outer skin layer, reedy ridges. This downward pattern has been likened to test tubes in a rack. Increased turnover of outer skin cells and lack of maturation lead to loss of the granular outer skin layer and extensive abnormal scale formation. Additionally, thinning of the outer skin cell layer covering the tips of dermal papillae and enlarged, winding blood vessels within these papillae can be observed. These vessels bleed when scales are removed, resulting in multiple tiny bleeding points, Auspitz sign. Neutrophils form small clusters within both the superficial outer skin layer, spongiform pustule of Kogoj, and the abnormal outermost layer, parakeratotic stratum corneum, Monroe microabscesses. Similar changes can be seen in superficial fungal infections, which need to be ruled out with appropriate specialized stains. Erythematous psoriatic plaques covered by silvery white scales are observable in individuals with lighter skin tones. In patients with darker skin, plaques exhibit a range from salmon-colored to hyperpigmented and generally display grayish scales. Microscopic examination reveals pronounced thickening of the outer skin layer, extension of the downward projections of the outer skin layer, psoriasiform hyperplasia, and prominent abnormal scale with infiltrating neutrophils. Clinical features. Psoriasis commonly affects the skin over the elbows, knees, posterior scalp, lower back and sacral regions, space between the buttocks, glans penis, and vulva. Changes in nails on the fingers and toes occur in 30% of cases. In most instances, psoriasis is mild and limited in distribution, while in others, it becomes widespread and severe. Treatment aims to prevent the release or effects of inflammatory agents. Mild cases are managed topically using ointments containing corticosteroids or other immune-modulating agents, whereas more severe cases are treated with phototherapy, which has immunosuppressive effects, and immunosuppressive medications targeting TNF function or Th17 immune responses. Thank you for watching, and be sure to talk to your healthcare provider if you have any questions or concerns about your medications and any health conditions you may have. Disclaimer: the information presented in this video is for educational and informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard or seen in this video. We would like to express our gratitude to our sponsor, First Cup Coffee, the original seed, for making this video possible. Shop firstcupcoffeeusa.com. First Cup Coffee, the original seed, is dedicated to providing high-quality coffee that fuels your studies and work with a rich and invigorating taste. We appreciate their support in bringing you valuable, free educational content. Remember to visit firstcupcoffeeusa.com for your daily dose of exceptional coffee. They also provide catering services for events and have a selection of fashionable clothing items for sale. Message them on Instagram at Coffee First Cup to receive generous discount codes. That's a wrap for today's lesson. I hope you found this video informative and helpful. If you have any questions or topics you'd like me to cover, let me know in the comments below. Don't forget to like and subscribe to my channel for more educational content. Take care, keep studying, and I'll catch you in the next video. Bye.